Good evening, all. Today is an auspicious day indeed. Let me invoke the divine blessings of Lord Ganesha on the occasion of Ganesh Chaturthi. On behalf of Juventus Healthcare Limited, we welcome you all to this mega national webinar on a very pertinent topic that is of relevance to every clinician today. The topic of discussion today is fiber, the mega nutrient for the management of diabetes. My name is Robin Nath, and I am the General Manager, Sales and Marketing at Lifestyle Division of Juventus. I consider it my proud privilege to introduce the esteemed faculty of this event who are nothing less than legends in the field of endocrinology. They are, in fact, experts who need no introduction, given their reputation, popularity, as well as the research work as scholars. However, for the sake of formality, I would like to present to you the chairperson of this evening's program, Dr. Sanjay Kalra sir. Sir, we are indebted to you and very happy to have you as a chairperson for this webinar.
Thank you.
Our speaker for this evening's program is Dr. Nitin Kapoor. Sir, thank you very much for accepting our invitation to be the speaker, and you are the right person to talk on this subject of your interest. It is indeed a pleasure to have both of you, sirs, on this platform this evening. Now, may I take this opportunity to request our chairperson for this evening's program, Dr. Sanjay Kalra, sir, for taking the session forward. Over to you, sir.
Thank you, Mr. Robin, and good evening. Warm welcome to everybody who is logged in this mega webinar. Now, the word mega can mean many things, but here it means big, huge, large. Mega is large not only in terms of size, it is also large or big in terms of impact, in terms of importance. And today we'll be talking about a nutrient that is large in terms of size and even larger in terms of its influence and impact on human health. We'll talk about a nutrient that is a nutrient not only for us, a source of nutrition not only for us, but also for our friends, trillions of friends whom we have. And who are these friends? These are the bacteria that live in our gut. Have we realized that many of us struggle with overweight and obesity? There are data sets that say that 1/3 of all adults across the world are overweight or obese. 1/3. So three becomes a big number. Many of us struggle with obesity. We try to lose weight. Sometimes we are happy. That is called ego syntonic obesity. Other times we are unhappy. That is called ego dystonic obesity. And a few of us become very, very upset with life, and that is known as schizoid obesity. We really get upset. There are many ways of reducing weight. Diet is important, exercise is important, but most of us need help. Apart from diet and exercise, we need that extra push to motivate us to bring down that initial weight. One way in which we can do this is by taking support of the trillions of bacteria that live in our gut, the microbiome. Another way that we can do it is by finding something to take care of our hunger pangs so that we don't feel very hungry and we don't reach out for that comfort food, that comfort chocolate or comfort ice cream. How do we do this? How do we do it in a nutraceutical manner? How do we do it in a manner where we do not have to take pharmacological therapy or go for surgery? Are there options? Are there not? We'll find out. And we'll find out from Professor Nitin Kapoor, who is India's leading voice on obesity management. He takes care of my weight as well. So, Dr. Nitin, perhaps more about that later once you're done with the talk. But Professor Nitin Kapoor, as already introduced, is consultant and head of unit at Christian Medical College, Vellore. He also serves as faculty at the prestigious Baker Institute in Melbourne, Australia. And he has coined the term barocrinology. And you will find across the world, more and more literature is coming from Asia, from South Asia, from India. And all that literature has got the Kapoor imprint on it. So, Dr. Kapoor, this Kapoor imprint, would you like to demonstrate that to us over the next half hour? And what mega nutrient do you have that you'll speak about to us?
Thank you so much, sir, for that very, very kind introduction. And thank you, uh, Mr. Robin and team, for having us here today. In the next couple of minutes, as Dr. Kalra very nicely pointed out, we are going to talk about mega nutrients. And here we are talking of how we can manage an ego dystonic diversity and make it ego syntonic, if I may say. So, may I request my slides to be in the show? And I think I would cover this topic by first talking about what are mega nutrients. And we've all heard about what is micronutrient, we've heard about what is macronutrients, but what is meganutrient is something that is we're going to talk about today. So till the time the slides come up on the show, we will just briefly describe as to how the classification of nutrients works in clinical practice. I think all of us during our medical school have learned that there are three big macronutrients that we talk about: the carbohydrate, the protein, and fat. And there's a lot of debate as to how whether it should be a low carbohydrate diet or a high protein diet that really helps in management of diabetes and obesity. More recently, literature has also emerged that it's not only the macronutrient composition, but even micronutrients, especially iron, folate, B12, are also linked to obesity. But maybe that is a topic for another day. For today, what we are going to talk about is the mega nutrient that does not really fit into the definition of either micro or macronutrient. So, friends, what is a mega nutrient? This is a paper that we published earlier this year talking about two mega nutrients in our body: fiber and water. So, why are they called mega nutrients? Well, as Dr. Kalra said, they are mega in terms of their size, they are mega in terms of the quantity that is required, and they are also mega because they have a huge impact, right? So if I say water, yes, they are required in very large quantities. It's 0 calorie, so you don't put on weight if you put on water in terms of fat. They have a big impact in metabolic health, and more recent literature on water has definitely shown how water can lead on to diabetes and other metabolic disorders, and that is also probably a topic of another day for discussion. But yes, what has been shown is that both deficiency and excess of these mega nutrients is detrimental to metabolic health, and if we are able to replace the normal amount of fiber and water here, it would make the homeostasis back to normal. But talking in terms of fiber in specific, yes, this is a nutrient that is required in much larger quantities. But more importantly, some people may argue, well, fiber is just a type of carbohydrate. Well, it doesn't really function fully as a carbohydrate, and I think to give its due importance in clinical practice, it is very helpful to really classify it separately as a mega nutrient. So let's look at this topic of fiber diet and diabetes, and I will cover this topic in five very brief domains. Let's start with the basics as to what is fiber, how we understand it, how do we classify it, what is the fiber in our food. Second important question that we'll address is, why is it important? Why is it important for us as physicians to talk about fiber to our patients with diabetes and obesity? Once we know that, we look at the evidence that is available, not only Western evidence, evidence from India, as to how fiber can help not only in prevention, but even at times even reversal of diabetes or even remission of diabetes. We must know how much fiber do we have to eat and how much do we have to recommend. What do the guidelines say, be it national, international, South Asian guidelines? What is the message for all of us on that? Also, something which is very important is to learn how different cooking methods can alter or modify fiber in our day-to-day diet. And maybe the last point, when we're prescribing fiber in our nutrition, how do we really prescribe it and what is the clinician's role in that? So, starting straight with the topic of what is fiber, and in common terms, when we talk of fiber, we talk of roughage. So, dietary fiber is commonly known as roughage. This is essentially the edible part of plant derived foods which cannot be completely broken down by the human digestive enzymes. And so ultimately they pass off the colon undigested. So I repeat, fiber is nothing but edible plant derived foods which are not completely digested by the body. Well, there's several types of chemical compositions, and if you really look into biochemistry of fiber, you would find so many classifications of fiber based on their chemical composition, solubility, their viscosity. What Dr. Kalra was talking about helping the trillions of bacteria that are there in enzyme, the fermentability of fiber, and there is so much to talk about it. But to make things simple for us, and I think for clinicians, if I was to classify fiber into two types, I would simply do it those which are soluble and those which are insoluble. So, what do I mean by soluble or insoluble fiber? Well, soluble fiber is a fiber that can dissolve in water to become a very viscous gel, whereas insoluble fiber is one that does not dissolve in water to become a viscous gel. Now, clinically, the key difference between these two types of fiber is yes, the soluble fiber is more fermentable and fermentable. So, if it is more fermentable, then it is helpful for our gut microbiota to produce all the good things that we require from them for a better cardiometabolic health. Whereas the insoluble fiber that does not get dissolved in water is less fermentable. But clinically, what we really need to remember is the thing that we've highlighted here in red. The soluble fiber definitely helps in satiety, but is helpful in also reducing the blood glucose levels and also the cholesterol levels. But when we talk of insoluble fiber, and yes, it also helps to reduce satiety, and therefore both the soluble and insoluble fiber helps in reducing weight. But the insoluble fiber is also good for people who are suffering from constipation because it improves the bowel movement. It provides that bulk to the stool, provides consistency. So, friends, so far we are just talking about what is fiber and what are the types of fiber, and just the simple classification of soluble and insoluble fiber is good enough for us as clinicians to remember. But why is there a separate webinar, and we call it as a mega webinar for fiber? Why is it important? Well, this is a recent review which was published uh, in 2022. This is in Diabetes and Metabolic Syndrome Clinical Research and Reviews. In fact, at 10 Journal, we see what Dr. Kalra and myself have contributed to this review. And I would say this is one of the most comprehensive reviews on fiber from an Indian standpoint that is available today. I think it runs in 10 pages. But what we are talking about today is importance of fiber in patients with diabetes. What we call this as is an FDN, a fiber-rich diabetes nutrition diet. And though conventionally we often talk about the importance of fiber in terms of glycemic control, it is also helpful for lipid control, for improving cholesterol levels. It is also helpful for weight management, as we discussed, that it helps to improve satiety and therefore reduce the weight. So, yes, what fiber's role in diabetes is not only to just manage diabetes, but also prevent. And I will show you a few evidence slides uh, from India in a couple of minutes. But how does fiber do all this magic? And all this time we've been talking about how we turn a dystonic, ego dystonic diabetes to ego syntonic. So how does the fiber does all this magic? And you see that there are three broad pathways to it. It's just not about the content of fiber in terms of volume. Yes, that is important in terms of the intrinsic effects that we have, but there are hormonal effects and there are colonic effects. From a hormonal point of view, yes, as we said, that fiber would either be digested as a soluble fiber in forming a viscous fluid or does not get soluble, but all it does is does increase the intraluminal viscosity of the food that we take. Therefore, the food is going to go much slower down the gut and therefore it will reduce the gastric emptying. Obviously, if the food is going slowly and gradually, the rapid absorption of glucose will not happen. the postprandial glycemia will be better controlled. If the postprandial peak of glucose is less, our pancreas would secrete less amount of insulin, and overall there is a good control of the postprandial glucose. What are the intrinsic effects of fiber? Yes, because of the volume, sheer volume of the undigested food that we have, it will cause increase in satiety. And the moment there's increase in satiety, we wouldn't have those hunger pangs, and we would consume less amount of calories and therefore will reduce weight. Not only this, it does help in fermentation, and therefore it really helps all the bacteria that are there, the good bacteria in our gut, to ferment these fibers and form what they call as the short chain fatty acids. And these are very, very helpful in terms of reduction in hepatic glucose, reduction in free fatty acids, overall improving insulin sensitivity indirectly, reducing the glucose levels, and overall helping in body weight management. So, cutting a long story short, what we really need to remember is that fiber is just not important for glucose control. Yes, it is helpful in diabetes, but it is also helpful in reducing weight by improving satiety. It is also helpful in reducing cholesterol, and it is also helpful in improving the bowel movements, especially in patients who often suffer from constipation. So let's see what is the evidence, and this is a study that we did, a longitudinal study from Kerala, where we looked at what kind of dietary patterns actually provide some kind of cardiometabolic benefit. And there are two types of foods that really come up when we look at our South Indian diet here in Kerala. And what we find here is that yes, lesser the fiber, more the refined food that we consume, there is an increased chance of having a higher HbA1c, increased chance of developing central adiposity, which we know is not good. So definitely, even in people who've not yet developed diabetes, these are just people who are high risk of developing diabetes or pre-diabetes. If we are giving good amount of fiber, we can prevent development of diabetes. But what of those patients who already have diabetes? And this is a very recent paper that was published, I believe, just last week. We're looking at how we can reverse or uh, cause diabetes in remission. And again, the kind of low calorie diet we give, obviously we need to give adequate amount of roughage in these patients along with low calorie, and that is something that is again provided with fiber. And the important message in this paper is that it does not only helps in reduction of the weight, the body fat, and the anthropometric parameters, but it helps in reduction of diabetes, hypertension, dyslipidemia, NAFLD, and the entire spectrum of metabolic disorders. So I think the topic for today should have been fiber and metabolic health, because its benefits are not only limited to diabetes but the entire spectrum of metabolic disorders. So this is why fiber is important. So now we've seen what is fiber, what are the types of fiber. We've seen that how it really helps in reducing not only glucose but cholesterol, weight, and improves constipation. Let's see how much fiber should we be eating. So again, going back to the paper that I mentioned a couple of minutes ago, well, looking at this table, we compare the three standard guidelines that we often follow in the Indian setting, looking at what the American Diabetes Association tells us, what the RSSDI tells us, and what the ICMR and the National Institute of Nutrition tells us. And all of them talk almost in the same language. So how much fiber are we supposed to consume? Well, the ADA talks about 14 grams per 1000 calories that you recommend to a patient. So if you recommend 2000 calories to a patient, you would be recommending 28 grams of fiber. What ADA also mentions is that yes, patients with diabetes should receive high fiber and a low glycemic index kind of a diet. And the best way to provide that is provide least amount of processed food. And the unprocessed food we definitely know has high fiber. Talking about the RSSDI guidelines, the National Indian setup, again giving a recommendation of 25 to 40 grams of fiber per day in patients with diabetes. What they recommend is both a mix of soluble and insoluble fibers, and as we saw, the benefits of both are slightly different, so might as well give the patient the benefit of both the types of fiber. And what it very interestingly also adds on is how we can customize the classic Indian diets by improving fiber. A very simple example here would be how, in South we have upma for breakfast, and how we can just add probably oats and maybe oats upma, and that could increase fiber. And obviously, we have different nutraceutical products as well that are convenient and can be used to improve the fiber content. Again, the ICMR NIN goes very robustly that we should be giving about 40 grams of fiber for every 2000 calories that we prescribe. Again, emphasizing both on the natural as well as nutraceutical methods of providing fiber. A couple of years ago, we wrote this consensus on medical nutrition therapy from a South Asian perspective. Again, what we mentioned here is in similar lines. What we need to remember is about 25 to 40 grams of fiber per day is helpful in patients with both diabetes and obesity. It's important to give that knowledge about both calorie and fiber to our patients. And I'll show you a very simple example. And this is a snapshot from my clinic in the obesity clinic here at Vellore. I'm showing you here four classic breakfasts that we often consume in North, South, West, and East India. In South India, we consume idli. In the East, we have what we call as rice flakes or muri. In the West, poha is a common breakfast, and North, sometimes bread is commonly eaten. Now, what you see here is that all the four types of breakfast have providing almost equal amount of calories, but a stark difference here is in the quantum of fiber that is there. So again, giving that knowledge to the patient that you're supposed to consume around 25 to 40 grams of fiber per day, you look at your food and how much fiber you're getting. And if you're not able to get it through your natural sources, there is more help available in form of nutraceutical powders. Very recently, we also published the Endocrine Society of India guidelines for obesity management. And again, what you see, what is highlighted in green here, yes, that again, speaking the same language, up to 40 grams per day of fiber is helpful for patients we manage with obesity. So, cutting a long story short, again, friends, the quantum of fiber, how much fiber we have to prescribe or eat in patients with diabetes, is clearly to the scale of 25 to 40 grams per day. So, with this, we move on to the fourth aspect of our talk, which is talking about how cooking methods can change or modify fiber. And this is again something which is very important that has to be taught to the patients. We often use different cooking methods, especially in the Indian foods, right? From soaking, boiling, roasting, or even pressure cooker is very commonly used. So, how does it change the fiber content? Well, overall, if you look at soaking, though the total fiber content is not much change, there is a change in the ratio in terms of the soluble and the insoluble dietary fiber. And this is especially important in terms of cereals, wheat, moong, where by soaking, the insoluble fiber comes down and the soluble fiber goes up. So, as we remember from the initial slide that I showed, the soluble fiber and the insoluble fiber both are helpful for weight, but the soluble fiber is probably metabolically more helpful in terms of diabetes and lipids, and the insoluble fiber, in addition, is more helpful for preventing or treating constipation. Talking about boiling, and again, there is a difference here. So, if we boil rice, the fiber content goes up, but if you boil wheat, barley, or nuts, the fiber content comes down. Roasting, and that to the temperature of about 80 degrees for at least 5 minutes, we see that again the roasting will increase the total dietary fiber in terms of white rice, moong, bean, and soya bean. But if you roast groundnuts, the fiber content comes down. So you see there's a differential effect, and it is important for patients to understand this rather than just blindly consuming a food product thinking it has high fiber. It depends on the method of cooking, and including pressure cooking as well, which does reduce fiber content in most foods. I think, like in medicine, we talk about everything that we give. We shouldn't go overboard. Excess of everything is bad. So, again, it's important to understand that we don't start with very high fiber diet on day one. We gradually step it up, and we wouldn't like to give it too much, and definitely not more than 60 grams per day. That has been shown to cause some amount of diarrhea, bloating, and flatulence. Again, it's important to take a good dietary history of allergies Many of the fiber rich diets could be through wheat based. Again, that needs to be avoided in our patients. By and large, overall, to minimize the discomfort of flatulence and bloating with fiber, the best way is to start slow. Maybe add a salad to one meal in a day, use of fresh and local seasonal fruits and vegetables. Again, it is helpful to use high fiber rich nutrition either through supplements or through cereals that is helpful in people with diabetes. And not to forget the other mega nutrient we mentioned in the beginning, including good amount of water. And this is always helpful in people who are consuming a large amount of fiber to also consume good amount of water. So with this, we move on to the last aspect of my diet. So where is the fiber in the Indian diet? And this is a very helpful chart, I would say, that has the amount of insoluble and soluble fiber in different commonly consumed Indian food items. This chart is available in the publication that I had shared before. And I just show how easy it is to prescribe dietary fiber in the diet. Easily, you can make it up to 30 to 40 grams, provided our patient knows how to take it, patient understands which food items have it, and also understands how the cooking changes, and if there is a deficiency, how the nutraceuticals can help. But the bottom line still is that no matter how much you prescribe, you need to make sure that the patient is comfortable in taking the amount of fiber that you're giving, and the patient understands its importance and it is aligned to the customs of the patient's culture and ethnicity. And you cannot just introduce certain kind of food items on day one when the patient is not used to having them. The long-term compliance of such diets would not be good. So again, go slow and go in a patient-centric manner. So these are the five brief domains that we covered about fiber diet and diabetes. And so, in conclusion, what I would say is the key important messages that you need to remember when you prescribe fiber diet in patients with diabetes, starting with what is mega nutrient. It's not only just talking about macronutrients, micronutrients are important, but talking about good amount of water intake and fiber intake is also important. It's also important to know what is fiber and the types of fiber, and of all the classifications, if one that you need to remember is soluble and insoluble fiber. Soluble fiber is the one that gets dissolved in water, becomes more viscous. The insoluble water does not dissolve in water, but the key important differences is regarding fermentation. Soluble fiber is more fermentable, unlike insoluble fiber. Soluble fiber helps in metabolic disorders in addition to losing weight. The insoluble fiber helps in reducing constipation in addition to weight loss. It's important for patients with diabetes to have fiber because it is not only for their glycemic control, in addition to weight, also helps to reduce cholesterol, also helps to improve constipation, which is helpful. There is enough and more evidence in terms of Indian literature as well. We saw these two studies how fiber is important not only for prevention of diabetes but also in bringing about remission not only of diabetes but other metabolic disorders as well. The average amount of dietary fiber that is recommended across international, national, and South Asian guidelines in patients with diabetes and obesity is to the scale of 25 to 40 grams. And while it's important to know the cooking methods that change the fiber content, it's also important to know that we shouldn't prescribe overzealously and a high diet of fiber more than 60 grams. And ultimately, what really goes a long way in a patient when you prescribe a diet which is good in fiber is that you make it more person centric, understand what the patient can do, and take the help of not only the natural sources but nutraceuticals as well. So at this point, I will stop here, but would be happy to take any questions. Over to you, Kalasa.
Thank you, Dr. Nitin. A wonderful presentation. And we have people logged in from across the country, nearly 1,000 to right now. And good evening and thank you from all of them. We welcome everybody. I noticed that many endocrinologists have also joined the discussion. We have physicians and we have other healthcare providers as well. So first of all, I'd like to thank everyone who has logged in. Thank you for taking care of our fellow citizens. Thank you for helping all of us as a country fight this obesity pandemic, the obesity epidemic. Dr. Nitin, you have given a very practical description of nutrition You've classified nutrients for us. Then you've classified the mega nutrients, and further you've talked about different types of fibers. In practice, do you see a difference between men and women, between people from different age groups? What is the fiber content like in different groups of people in your clinic?
I think that's a very, very important point. And what is important is, and that's the reason that many international guidelines today mention about fiber per 1,000 calories. So it depends if you have a young child, if you have a pregnant woman, if you have an athlete, if you have an elderly person, your total calorie will be different. And that's how we would be able to tailor our amount of fiber content that we have to prescribe. So easily we can give about 12 grams per 1,000 calories, 24 grams per 2,000 calories. So I think the first step would be to decide how many calories you are giving, and then you can decide the fiber, and that will take care of the gender and the age difference.
Uh, Dr. Kanchanmala asks, how does fiber help in diabetes control? You've mentioned that, but is it just a mechanical kind of a control, or is there a microbial, metabolic component to it? So, mechanical, microbial, metabolic, mood related, what happens?
Several things happen. So I said there are three legs to it. The first important leg is because of the slowness of the food transition in the gut, the postprandial spike comes down, and therefore the insulin release comes down. Now we know that very high amounts of insulin is not good as well, and this is something that helps to take care of the postprandial hyperglycemia. I talked about the fermentability of fiber, and again, more for soluble fiber, and that helps in the gut microbiota to improve the production of short chain fatty acids. Now, these are again something which is very, very helpful in terms of reducing the fatty acid content, reducing the insulin resistance, and this is also something that we really helps to reduce the insulin resistance and diabetes. And obviously, the big factor of it being a mechanical thing of providing more satiety, reducing weight, and that indirectly also helps to control glucose. So there are several ways how it does it.
So, Professor Kapoor, if we can paraphrase that, if you take a fiber preparation, provided it is crafted properly, if you take it before a meal, that will reduce the glycemic load, and it will also reduce the glycemic index. Would that be a correct statement?
Absolutely, both the things.
So when it reduces the glycemic load and the glycemic index, then automatically, as Dr. Uday Shah points out, it will help in controlling the post-meal glucose fluctuations. So does it reduce variability as well?
Again, that would depend on the quantum of fiber in each meal. So if somebody is not consuming fiber in one meal and taking more in one meal, so then it may not. But yes, if it is uniformly distributed across the day, it should reduce the variability as well.
And there will be some people where actually maybe fiber would not help in controlling fluctuations. One example is pancreatic diabetes. So a person with pancreatic diabetes, would that be a good candidate for giving a fiber supplement?
Definitely not. So, in patients with pancreatic diabetes, though the predominant pathogenesis is about poor absorption of fat, these are patients who are already struggling with flatulence and bloating because of malabsorption of the pancreatic enzymes. And then, definitely, the carbohydrate absorption, if you are providing a very high fiber diet, would just add to their misery. So, I wouldn't like to try it there.
Now let's look at other cases. So Dr. Chenmay Naik asks, does soluble dietary fiber help in relieving constipation? And if you have an elderly person, so we are speaking of geriatric diabetes, the person is not frail, the person is fine, doing well. The complaint is constipation, and he feels that because of the constipation, his glucose is high all the time. Then would fiber help such a person?
A very common myth, I would say, and many people would feel that constipation is the reason for all their health problems. Relieving constipation improves the quality of life of patients. Insoluble fiber, more than soluble fiber, I would say, is more helpful. The insoluble fiber is providing more bulk to the stool, and therefore it relieves constipation more than soluble fiber. So overall, fiber, yes, helps with
Hmm.
constipation.
So, insoluble fiber or a mixture, Dr. Chinmay Naik. And If the patient says, relieve my constipation and then my glucose will come down, you say, yes, we'll do that. The patient's chief complaint is constipation, and the patient's chief concern is loss of quality of life or loss of metabolic control, which he attributes to the constipation. If you relieve the constipation, you're a good doctor. So when the patient comes to you for the first time, you handle the chief complaint. And insoluble dietary fiber or a mixture would actually be a good idea, maybe guar gum. Do not argue with the patient on day one. Build a rapport, build trust. And the only way you can build trust is by correcting the constipation. Otherwise, he will find somebody from alternative care to do that. And then after that, you can talk to him about other aspects of maybe GI motility and metabolic control. We already took Dr. Kanchan Mala's question, and the answer was glycemic index and glycemic load both come down with the steroids, with the fiber, sorry. Dr. Chinmay Naik is from Pune, and warm welcome, sir. Thank you. Dr. Deepaji asks, what is the best way of taking flax seeds and sunflower seeds in OPD? Do patients come to you frequently with such fad diets and questions about them?
Oh, yes. So a lot of patients would often ask about all this, and I'm blessed to have a very good dietitian in our department who is able to handle most of these questions than me. But yes, I would say that yes, a lot of myths are available in some of these uh, uh, food products do help in adding on to the bulk and again reducing the calorie intake and reducing satiety. But I think we have to go by evidence-based medicine, and per se, what we talk to our patients should be evidence based and not just uh, something that is off
Yeah.
the fat.
Yeah. So they may help in increasing satiety. Initially, the patient may feel very good, but you will find that no person continues with such a diet for a long period of time. You ask anybody. So, at any point of time, you will find that, let us say, there are 100 people who smoke in the country. So, 99 of them say, I've quit smoking. But they quit smoking for half a day, 1 day, 1 hour, and then they restart and then they quit again. So, the total number of people quitting smoking might be 1,000, while the total number of people who are smoking is 1,000. So similarly with the seed diet, it happens that way. Dr. Kapoor, how common is this in practice? Patient is hypothyroid, very well controlled. She comes back with poor control. You take the entire history, you're not able to find a reason. The patient is actually complying with therapy as well as adherent. And then finally, it comes out that I had begun taking fenugreek water, or I had begun taking coriander water in the morning along with the thyroid medicine, or 15-20 minutes before after that, or maybe flax seeds or sunflower seeds. So how frequent is this?
Oh yes, I would say it is very common. I think the constituent changes from North India to South India. What you mentioned was probably more common in North. In South, there are certain herbs which are very common in the southern region, in Karnataka as well as in Tamil Nadu. So I think whatever said and done, I think our education is very important to the patient as to how to take these tablets and how to space them with whatever else they want to take out of their beliefs. I think that onus lies with the physician to educate properly.
So this question from Dr. Vikram Singh Chauhan and Dr. Madhukar Saraswat, a person who is hypothyroidism, who has hypothyroidism and is living with obesity as well. So at what time should she take thyroxine? And she wants to take a fiber preparation also before breakfast, because otherwise she feels very hungry and she cannot stop at 2 or 3 idlis. So what time gap would we want to suggest?
Right. So, as per all the guidelines, today thyroxine should be taken at least 40 minutes before you consume any of your food products, and which is possible many times if you take that as the first tablet as soon as you get up, and make sure your first bed tea or whatever else you take, or you want to take any of these other nutraceuticals, you delay it by at least 40 minutes. So, I often tell my patients three rules: it has to be taken empty stomach, it has to be taken with at least a 40-minute gap, and it has to be taken daily. And I'd also remember what Dr. Sheshadri taught me, and he used to tell his patients, like many times patients will complain, doctor, why is it daily? And how can I remember? He would say that you brush your teeth every day. Do you complain about it? Would you do it lifelong? The patient would say yes. So he'd say, if you don't do that, that's not important. Thyroxine is more important. So I think It's just about talking to the patient properly and convincing them.
and explaining. Dr. Meeta, Dr. Zahir Patwegar greeting you. Also, Dr. Dhanraj and Dr. Swapnil Aswar. Uh, One more question is, sir, initially you spoke about fiber and diabetes versus fiber and metabolic syndrome. So, these fiber preparations, do they help in reducing triglycerides as well?
Definitely. So I think the bottom line of metabolic syndrome is obesity, and something that is able to reduce your obesity and insulin resistance will have an impact on all the parameters. We've shown that in one of the studies that has showed not only diabetes, hypertension, cholesterol, including triglycerides, but also fatty liver. So the answer is yes. Overall, it will help to reduce triglycerides because you will eat less, your satiety will be more, and your weight will come down.
And of course, triglycerides is not a primary target for us. But see, earlier in practice, when we were students, we were taught about symptoms and signs. Now, the number of people who present you with signs is relatively less. If you were to take out central obesity and obesity, if you don't calculate, if you don't count that as a sign, because more and more people come into the OPD in an asymptomatic or relatively asymptomatic state. They want to promote health. They want to prevent illness. So if you look at signs only, you will not have patients. But now patients come with complaints and concerns, symptoms and concerns. If the patient's concern is constipation, you have to fix that up. If the patient's concern is high triglyceride or low HDL, then that has to be fixed up. If you tell the patient, I am the most educated PhD in the country, and I have read the guidelines from 6 continents, and they say don't bother about triglycerides. On the other hand, there is another alternative care practitioner who says, yeah, I know how to bring the triglyceride down. Now, it's not difficult to decide where the patient is going to go. The patient's concern is a high triglyceride. So, uh, in such situations, let us say normal cholesterol, high triglyceride, a very low HDL, you may not be willing to initiate or to intensify statin therapy. But these fiber therapies can be tried. Now, it is basically lifestyle modification. You can add the fiber to that, and you can tell the patient, we are doing a therapeutic trial for 6 weeks. Let's see what happens. Patient says, I cannot take the fiber 3 times a day before each meal. So you ask, in which meal do you think you're taking the maximum fat? Where is the maximum ghee or butter hidden amongst all your 3 meals? You take it before that, maybe 1 or 2 meals, and even that should help. So try this as well. Dr. Vishal Srivastava says, sir, you spoke of metabolic syndrome. In your experience, when we prescribe medical nutrition therapy to patients without using drugs such as orlistat or semaglutide, uh, are they able to reduce weight? Do you have patients in your clinic who are able to reduce weight with just education and medical nutrition therapy?
I would say definitely yes. And I would say that is often my first step of treatment. I would never start somebody on medication on day one. When I see a patient for obesity management, and it's a team management, I would see, but my dietitian and exercise physiotherapist would also see and counsel the patient. And the patient would, if they really try, they would be able to lose 3, 5, 7, some amount of weight, some 7 kgs or so. But they will come back to you in 3 to 6 months and say, Doctor, I've lost about 5 kgs of weight and I'm trying even harder now and it's not coming down. And that's the point when you'd like to step up your anti obesity management, either in terms of meal replacements, fiber, or even medical therapy, but not on day one. And yes, they do lose with only MNT.
Dr. Daisy Maheshwari, Dr. Rakesh Kumar, and Dr. Hardeep Ruproy all greeting you and thanking you. Dr. Sarfaraj asked a question which we just discussed, but if you can repeat that, is there any role of insoluble fiber in the management of pancreatic calculus related diabetes?
I wouldn't like to try insoluble fiber in pancreatic diabetes because it will just increase the flatulence and bloating in these patients. The insulin requirements in these patients is minimal, and often we can control their diabetes with insulin easily.
One question from Dr. Uday Shah. So, any fiber preparation available? Let me take this, which can take care of diabetes, weight, and constipation. So, fiber light is not a bad idea to try, Uday, and just try that uh, maybe once or twice a day in the beginning before the heaviest meal. and that would be a pragmatic suggestion. Do remind your patient that the patient has to continue with lifestyle optimization. So a little bit of exercise is needed, a little bit of stress management, sleep hygiene, avoiding substance abuse. All these things are also important. Sir, a question from Naveen Prince. Uh, Fiber supplements that you have mentioned. So the dosage is roughly 10 grams per sachet, and each sachet costs less than 50 rupees, 40 something rupees. So how do I prescribe it? What do I tell the patient? Should the patient take it in hot water, cold water, lukewarm water? Should the patient take it while standing or sitting, while standing upside down? Can the patient go for a walk after taking this, or does the patient have to remain sitting at home?
So I think we make it simple for the patient, and as I mentioned that doing it before the heaviest meal is the best option. Giving it some time definitely will help to provide that satiety that is required to reduce the food intake for that heavy meal. Drinking water is important, as I also mentioned, and yes, I think the preference in which the patient would be compliant would be the best way forward. And yes, at least give 15 to 30 minutes gap after taking this before your meal would help.
Sir, two very insightful questions. One comes from Dr. Satya Priya Jha. Dr. Satya, allow us to structure your question into two parts. So the question is, the stem is, can a meal be replaced by fiber supplements? That's the stem. Preferably dinner. In persons who are on sulfonylurea or premixed or intensive insulin. And also in persons who are not taking sulfonylurea or insulin. So the stem is, can a meal be replaced by fiber supplements?
Right. So I think if my patient is able to understand the overall importance of all the macro and micronutrients, and the patient is educated and is looking for cutting down calories, yes, fiber can be used as a supplement in those patients, provided the other meals are well taken care of in terms of the nutrition requirement. Definitely not in patients who are on sulfonylureas or on insulin, because we don't want them to develop a hypoglycemia. But there are good fiber rich supplements which can be used as a meal replacement in those patients. But yes, so the short answer is that in those who are on drugs that cause hypoglycemia, I wouldn't like to try and replace a meal with fiber.
Another insightful question from Dr. Huda Khan. Madam Khan says, we have a lot of patients with diabetes, and many of them have comorbidities. We always speak about renal complications, cardiac complications, and we forget the gut. Now, many of our patients have got gastritis, gastroparesis, various GI symptoms. So, her question is just some clinical tips from your side, sir. In some of these situations, high fiber may actually aggravate the condition. In others, it may help. So, just some general tips. What kind of a GI history should we take? Where are fibers strongly indicated? Where are they contraindicated?
So I think a very important question. So I think it's important to ask the patient about their current diet and understand how much fiber they are actually consuming at this point in time. With regards to their GI symptoms, patients who have predominant constipation would benefit more from fiber than those who have diarrhea related problems or loose motion kind of a problem. They would benefit less. Overall, I would say that we should also make sure that the quantum of fiber that you prescribe shouldn't exceed the limit of 40 grams. Otherwise, that itself will start inducing symptoms. Understanding the other drugs that the patient is taking, which may also alter the GI milieu and the GI symptoms, should also not be coupled. So, if my patient is taking fiber and I'm starting along with that two or three anti-diabetic agents which aren't really good or friendly with the gut, maybe alpha glucosidase inhibitors and DPP4 inhibitors. So, if all these drugs are started together, maybe the patient would get symptomatic. The simple mantra of using fiber is start slow, gradually build up. Don't start 40 grams on day one. Start 10 grams, maybe give patient time for 2 weeks, then step it up to 20 grams and gradually build it up to what is required.
One more question coming. This is about NASH. So the question is from Meera ji and Dr. Navneeta Narendra Pandey ji. Uh, a few months ago, there was an article in the world-renowned journal Hepatology where they said that intermittent fasting can be a treatment for MAFLD, metabolic associated fatty liver disease. So, sir, first of all, what is MAFLD or MASLD? Secondly, if intermittent fasting or weight loss is a treatment for this, and I find it difficult to fast for a long period of time, can I use a fiber supplement when I'm feeling these hunger pangs after maybe 8 or 9 hours of fasting? This is assuming that the patient has got only MFLD and does not have diabetes, is not on any other drugs that you just spoke about, on sulfonylureas or insulin.
Agree. So, first question about what is this NAFLD and now MAFLD and now more recently MASLD. So, basically, NAFLD is non-alcoholic fatty liver disease. This is a term that was used for many years. 2 years ago, a paper in hepatology came up saying that it shouldn't be just non-alcoholic because a lot of people who don't consume a lot of alcohol still have fatty liver, and so they thought it's more important to relate it to the metabolic problems of this disease. So they changed it to MAFLD, that is presence of fat in the liver along with two metabolic problems called as metabolic uh, associated fatty liver disease. More recently, in the last 6 months, they felt the word fatty is stigmatizing. You shouldn't be calling anybody to have fatty liver because you should call it more scientifically. And so they changed that word fatty to steatosis, a scientific term in terms of liver fat. And that's how the recent term, and there's a lot of controversy about the change of this nomenclature. Now, the question about how intermittent fasting can change or reduce the incidence of MAFLD, I would say the basic mantra still there is calorie deficit. So if you are eating less frequently, ultimately you are consuming less calories, and therefore you would be able to reduce the fat in the liver. Definitely not recommended on people who are on insulin and on sulfonylureas, but yes, if you've been fasting for a long time and before you go on for the meal that you're going to eat during your non-fasting time, again taking fiber would be able to reduce your hunger pan.
So, point well taken. The drug can be used, fiber can be used, but do keep in mind all the other comorbidities that may be there and make sure you are sensitive to them. It is also a good idea, like Dr. Nitin said, not to use stigmatizing language. So, avoid using words which may sort of hurt your patient. Of course, it always helps if you are a healthcare professional who himself lives with obesity, and then patients don't mind, because then you're teasing yourself, not the patient. Dr. Rajiv Kumar Jha points out that increasing soluble fiber leads to reduction of HbA1c levels in persons with type 2 diabetes. So, therefore, type 2 diabetes is an indication actually for fiber therapy, for increasing fiber content. It is not a contraindication. Dr. Uday Shah says, sir, any cardiovascular outcomes on diet and diabetes? Uh, can diet reduce CVOTs? Though this is a very difficult zone to handle.
Right. So I think looking at it step by step. So obviously, if your diet is helping you to lose weight, your cardiometabolic risk factors come down. We did a study in Kerala that we follow a big cohort there, and we published how the cardiovascular risk could come down by just instituting a good lifestyle modification by reducing calories, improving exercise, stopping to smoke, and reducing alcohol. And that has shown a significant impact on the cardiovascular risk as calculated by the Framingham Heart Score. But I think definitely if you are able to reduce weight, not only one time but sustainably maintain it for a long time, I think there are no two ways that it will reduce your cardiovascular outcome.
Dr. Devbottam Sengupta says, Dr. Dev asks, can we use in inflammatory bowel disease and in irritable bowel syndrome?
So irritable bowel syndrome again of two types: constipation predominant and diarrhea predominant. So constipation predominant would definitely be helped by fiber, often prescribed. I would say diarrhea. I wouldn't like to use it. It would just probably worsen the symptoms. Nor would I like to use it in IBD because in those who have inflammatory bowel disease, we don't want their gut to be troubled and bleeding to be precipitated by the use of flatulent substances.
Dr. Shilender Pathak poses a query. Um, what is the average? What is the extreme answer to how much weight reduction can be expected with a high fiber diet over a particular duration?
I would say it's $1 billion question, but how I would answer is it depends on how much calorie reduction the patient is able to do by increasing the fiber. And it depends a lot on the patient. Patient A who's given the same fiber but is able to really discipline himself very well by reducing, say, about 300 or 400 calories per day would easily be able to lose 2 to 3 kgs in a month. Whereas the same patient prescription for patient B who takes the fiber and takes the food also as much will not be able to lose any weight. So I think it is just not only about the fiber, but how well you counsel the patient to overall change the diet.
So, Dr. Nitin, what is the role of the prescriber? Now, let's take two extreme examples. Supposing I come to you and you say, "Oh, Sanjay, your weight is that is censored. The answer is censored. It's in 3 digits. Your BMI is this much. This is what your cardiovascular risk is, and you've not lost weight for the past 50 plus years. So I doubt if you're going to reduce weight now. I have no trust whatsoever in you, and I have uh, no expectations from you as well. However, because I have to write such and such a medicine, let me write maybe a GLP-1 receptor analog, which costs 300 rupees a day. And I will also write a fiber, which costs maybe 100 rupees a day, taking twice a day. And go back and come back and tell me if you've lost weight. That is one extreme. The other extreme is welcome, Sanjay. Okay, you are struggling with weight. Now, see, you've already crossed the toughest part of the bridge. You've already done that. You've decided that you want to seek medical care, medical support. This is the most difficult thing to do. Now that you've done that, the rest of it is going to be a breeze. We have multiple things available for you. Would you like to choose a drug, an injection, a tablet, or maybe something nutraceutical? So, okay, nutraceutical. Let's begin by doing this. Let's make small, tiny changes in your lifestyle. This fiber preparation will help you reduce your appetite. You won't have those hunger pangs, and then come back to me in a couple of weeks. So, Dr. Nitin, what does all this tell you about, and any tips you would like to share with us regarding communication?
So I think we have to shift the focus from the doctor to the patient. So in both the examples that you said, yes, I think the second example is definitely more friendly. But what I would do is, I think I would like to know from my patient whether they want to lose weight or not. I have the same patient A who's not interested, brought by a spouse, a family friend, or sibling or parent, and they are saying, "Doctor, isko wazn kam karna hai." That and the patient is not interested. That doesn't help. I'm not going to spend a lot of time. I'm going to tell them that there are options. When you think you are ready, you should come back. Patient B, if the patient is very interested, and even if they have not lost weight in the past, but if the patient is driven, there are ways to help the patient stepwise again. But I think the focus from what the doctor tells, it's more important to understand what the patient wants and how the patient can drive the treatment rather than the doctor.
So, point well taken. Make sure that the conversation is person centric, not doctor centric. And if the person is willing to lose weight, I mean, like we said, that's the toughest thing. They've already come to show you. So, you've crossed that toughest part of communication. It's already 8 p.m. We never realized, Dr. Nitin, speaking with you is such a breeze. Do your patients also say the same thing to you? That we look at your smile and then we are 99% okay.
Depends on the patient, but
And
thank you.
depends on Dr. Nitin's mood. But today's a nice day. I would like to thank Dr. Deepa, Dr. Vishwatej, Dr. Satyapriya, Dr. Muhammad Rashid Ali, and Dr. Sarfaraj. Thank you for your kind words. It is this which keeps us going. Dr. Raghupati has a question. What is the glycemic index? So that I think would be minimal here with the fiber light preparation. But in 10 grams, there are only 19 calories, 1 9 calories in 10 grams. And that provides so much of satiety that you actually don't need to bother too much about eating extra food. And in those 10 grams, it is about 6.7 grams of fiber. So if you take, let us say, two helpings of this, that is 13 grams, and along with that, the fiber that is present in the normal Indian diet, that should suffice. So you are able to achieve the recommended daily allowance. Dr. Nitin, any idea about the fiber preparation and the specific glycemic index? Do you think it would have been calculated?
It will be very low overall. I'm not
The,
sure of the
the,
exact this thing. Yeah.
yeah, the actual point is that in the fiber preparation, the carbohydrates are 8.8 grams, 8.8 grams for 10 gram, which includes the fiber. So you have only about 2 grams of non-fiber carbohydrate, just 2 grams. So I think there will be no glycemic index. A quiz question, Dr. Nitin. You are famous as a quizzer across South Asia. So what is the glycemic index of an egg, and how do we extrapolate that to today's topic?
Excellent. So the glycemic index of an egg is zero, and I think all of us would know that. But what is important is not only talking about the glycemic index, and this discussion came before. It's a glycemic load that, together with the index that we look at, and how it impacts the nutrition of the patient. So if your glycemic index is helping, I mean, if your food is helping you to reduce the quantum of food that you're taking, I think glycemic index, glycemic load are all just adding complexities. And if your satiety has come down, overall your glycemic load will be less, your glycemic excursion will be less, and satiety will be more.
Yeah. And if you have any non-carbohydrate or low carbohydrate food stuff, the glycemic index is zero. Glycemic index will be calculated only for a food which is carbohydrate rich. So therefore, the glycemic index of the fiber is not important. What is important is, like Dr. Kapoor said, what is important is that it reduces the glycemic load and the index of the food that follows, of the meal that follows. Once again, Dr. Nitin, it's been great being with you. You had promised us a mega webinar and you've achieved much, much more than that. So this has actually had a mega impact on our information, on our knowledge. And I hope that tomorrow morning it has a mega impact on our patients' health as well. I'd
Thank
like
you
to
so much.
thank you for, yeah, I'd like to thank you on behalf of everyone who is logged in. So many messages coming on the chat box. Thanks to everyone who has been with us. And I'd like to welcome Mr. Robin back to give the vote of thanks.
Thank you, sir. It has been a wonderful session and so many comments coming in and so much of queries. It appears that this topic is a hot topic and more discussions need to be done on this. And thank you both for making it possible, sir. I would like to invite my colleague now, Sohan, on stage. Sohan, can you come and offer the vote of thanks, Sohan?
Yes, sir. Uh, am I audible?
Yeah, yeah. We
Yes.
are not able to see you though.
1 second, sir. I'll just check. Okay. I hope I'm visible now.
Yes.
Okay. Good evening, all. It has indeed been a very interesting, informative, as well as interacting webinar this evening. I am Sohan Shrishimar, and I consider it my proud privilege to offer the vote of thanks. On behalf of entire Juventus team, I express my heartfelt thanks to Dr. Sanjay Kalra sir and Dr. Nitin Kapoor sir for a wonderful session we had that kept the audience glued to the screen and makes even a tough subject really very interesting. Thank you, sir, for making this possible for us all the time. I shall be failing in my duties if I do not thank our esteemed participants with whom this event would have not been possible. We thank you all for sparing your time, and we believe you would have been benefited from the deliberations. Should you require further information regarding Fiberlite, unique 4-in-1 soluble dietary formula for the management of prediabetics and diabetics. We at Zuventus Healthcare Limited have always been striving to strengthen the therapeutic Ayurvedic medications for our doctors with innovative products with high quality. I thank you all and promise to be back soon with another interesting webinar and to have you all with us again. Thank you so much.
Thank you, sirs. Thanks a lot. And thanks everyone for logging in and making this possible for us. I think it has been a wonderful webinar we have ever had, and look forward to more such occasions in the future too. Thank you, Kalra sir. Thank you, Nitin sir.
Thank you.